Adverse effect mainly is the GI side effects, which are generally dose-dependent and self-limiting. Usually, we start off with the low dose, like 500 milligram daily, with the slow titration up. Okay, extended release preparation may minimize the side effects. Just to remind us, such use of the metformin is off-label, but the pros and cons needs to be discussed. There are actually evidence showing that this may help a little bit, although not to a very great magnitude. Other obesity drugs like Orlistat, liraglutide, I think this has been studied. They result in statistically significant reduction in BMI and waist circumference, but the magnitude in general is pretty modest. So, and currently, there's no good evidence on the role of these drugs in improving fertility or in outcome following assisted reproduction so far. So I could find two recent systematic review or meta-analysis published last year. So actually, the studies seems to be in favor of Orlistat comparing with metformin, and this meta-analysis actually compares the different types of anti-obesity drugs, and the liraglutide seems to be the best, especially when it is combined with metformin. And as I said, the magnitude of reduction, actually, this is just modest. For those who are morbidly obese with BMI, say, beyond 35 or even beyond 40, then probably drugs or even lifestyle plus the drug alone may not satisfactorily work. So we have to refer those patients to Daniel for the bariatric surgery. Okay, so bariatric surgery for refractory cases of morbid obesity may be required, like those with BMI more than 35 or in the presence of obesity-related comorbidities who failed attempts of weight loss for more than a year. Is it the usual criteria that you use to consider for bariatric surgery? Not that simple, right? So to the gynecologist, this is a simple statement in our guideline, but of course you have to assess them on individual basis. There are limited case series which showed improved spontaneous ovulation, hyperandrogenism, and metabolic profile. But for the reproductive outcome, I think there are not many prospective data regarding the reproductive outcome. Yeah. Just one remark that I think would be important is weight loss intervention should precede any planned pregnancy, but not during pregnancy. Yeah. If the woman gets pregnant during the course of active weight reduction, actually adverse perinatal risk has been reported, such as a small for gestational age, premature delivery, and possibly increase in infant mortality. Right? This is possibly due to the malnutrition, where if the woman happens to be actively losing weight during the course of pregnancy. So weight loss should be in the pre-conceptional period. Okay? One should embark on the planning to get pregnant, then I think it's not advised to actively reduce her weight anymore. Okay? Pregnancy should be avoided during periods of rapid weight loss and for at least 12 months after bariatric surgery. And if she happens to get pregnant inadvertently in the meantime, then it's important to monitor the fetal growth intensively during her pregnancy. So just to sum up, women with PCOS have higher propensity of weight gain and obesity, presenting significant concerns impacting on health and emotional well-being, with a clear need for prevention and intervention. Obesity itself exerts adverse effect on ovulatory dysfunction, reproductive outcomes, as well as on the cardiometabolic risk in the long term, and regular monitoring for weight changes, blood pressure, lipid profile, GTT, these are important. Lifestyle modifications is the important first line for the treatment of PCOS women with obesity, and the measures as simple as dietary calorie intake and exercise. No magic here. Or sometimes we may consider adding metformin or other anti-obesity drugs as an adjunct. The role of the anti-obesity drugs and bariatric surgery in terms of the reproductive outcome is still controversial, but it may be considered in selected cases who are refractory to the weight reduction exercise. and pregnancy should be avoided during the course of active weight reduction treatment. So these are the messages that I want to convey, and I hope I've convinced you that this is really an important topic in obstetrics and gynecology. So thank you very much.